Okay, so here we are with the last week of the semester, and it's about other endocrine disorders. I mean, diabetes is the big endocrine disorder, I guess, that you are likely to have to deal with in primary care. The number two being hypothyroidism. So even though hypothyroidism is, from a pharmacologic perspective, is about replacing the hormone, and I don't have a whole lot to say about that because it's a hormone and it's not, it's not a drug. But anyways, that's like the topic of this is thyroid, and then just a quick nod to some of the other things that you are less likely to see, but I just feel like for the sake of completeness, we should talk about them. And then we'll be done for the semester. Okay, so hypothyroidism, this is the most common thyroid disorder, and I think it is statistically the second most common endocrine disorder that is managed by primary care providers. So there's just a couple of statistical kind of things, I guess, about it here. More common in women and men because most hypothyroidism is autoimmune, and autoimmune disorders in general tend to be more common in women than men. Hypothyroidism may be primary, in other words, the hypothyroidism is the primary disease state itself, or secondary, where suppression of the thyroid hormone function, thyroid gland function, is a consequence of something else, like post-radioactive ablation, or, oh God, what's the word I want? Oh, there's drug therapy. Like if you have a patient who's on drug therapy with iodine in it, the iodine, like amiodarone or lithium, will suppress thyroid hormone function and ultimately make the patient hypothyroid. So primary or secondary, again, consequence of drug therapy, like I just said. Let's see, frequently a consequence of curative therapy. Okay, so I'm being repetitive here. Curative therapies for hyperthyroidism, primarily radioactive ablation, which is the curative therapy for Graves' disease, which is autoimmune hyperthyroidism. And again, the most common cause of hypothyroidism is autoimmune thyroiditis, also known as Hashimoto's thyroiditis. So I know this isn't a disease management course. I just couldn't help myself. The thing about, because when it comes to drugs, all there is thyroid hormone replacement. It's really pretty simple. But remember that thyroid hormone is one of the few hormones that affects virtually every single cell of the body. The thyroid hormone is the hormone that sets the metabolic rate. From a purely biological perspective, every organ system, the body is made up of organ systems, and every organ system is made up of an organ, and an organ is made up of individual tissues, and tissues are comprised of cells. And the cell is the smallest, like the smallest level of independent function, like that's the smallest independently functioning unit. And the nucleus is, of course, where the code for every cell is contained, and how often a code is expressed by the DNA or expressed from the DNA is determined by thyroid hormone. Thyroid hormone sets the rate of gene expression. Every cell in your body has a job to do and has an intrinsic rate at which it does it. And that is driven by thyroid hormone. So the first thing is that because it affects every single cell of the body, when the patient has a deficiency in thyroid hormone, as is the case in a hypothyroid patient, there is the potential for every single body system to slow down, and theoretically, you could see symptoms in every single body system. It almost never happens that way because every system is driven by a series of drivers or triggers. No system relies on just one trigger to function. If it did, we'd be in big trouble if that trigger failed. So every organ system has multiple triggers that drive it, and they're virtually all capable of compensation. So the bottom line is, yes, a hypothyroid patient, where's my little pointer thing here. Hypothyroid patient can demonstrate a slowdown of virtually every body system. The hair can get thin and coarse because hair follicles are not generating at the appropriate metabolic rate. They are too slow, so hair falls out and it's not replaced. Hair gets thin and breaks off and it's not replaced. The brain can slow down because mental acuity, mental processes are not driven at the appropriate rate. When you see a patient who's hypothyroid and has central nervous system symptoms, it's like they just can't process stimuli. Like you talk to them and you can watch them trying to mentally process what you said, but it just takes too long. One of the most interesting phenomena is when you're running behind at work, you have like 3 other patients waiting for you in 3 other exam rooms. and you're trying to get a history from a symptomatically hypothyroid patient, and they just can't respond to you fast. Like, you ask a question and it takes them like a long time to process it. um, they tend to get intracellular fluid accumulations because their rate of metabolism slows. So a lot of patients who are clinically, symptomatically hypothyroid will look puffy everywhere. The face will look puffy. They get like pretibial edema, lower extremity edema. Um, if their gland is trying really hard to make hormone, like in a patient who's iodine deficient, and so the gland itself is just fine, but there's not enough iodine to make thyroid hormone, they will then get gland hypertrophy and develop a goiter. But that doesn't happen as much in this country because for us, most hypothyroidism is not a consequence of an iodine deficiency. Certainly, cardiovascular system slows down, the pulse will get slow, the blood pressure will drop, the vasculature will dilate, slowing of skeletal muscle activity. Like, constipation is a classic hypothyroid patient problem, always difficult to separate from the patient who's just constipated because either they're female or their diet stinks, which is very common in this country. Cold hands because of poor circulation. Menorrhagia or metromenorrhagia, heavy periods, because the process of endometrial turnover just takes too long. So periods tend to be slow and heavy. Their intrinsic ability to tamponade is diminished. And then again, weight gain, activity or cold intolerance, because a byproduct of metabolism is heat. And if you are hypometabolic, which is basically what you are with hypothyroidism, you don't generate enough intrinsic heat. Decreased sweating, dry skin, because even dermal turnover is slowed down. So usually, your skin turns over somewhere around the rate of every 5 to 7 days. Your old skin cells slough off and new ones develop. And that's why you're not constantly running around with old skin. It's sort of like your own little peel, I guess. But if you're a hypothyroid, your dermal cells won't turn over as quickly. So what's on the surface are old cells that had been exposed for too long to like soap and detergents and shampoos and the sun and dirt and everything else. And the skin just everything just slows down, or it can. But the truth is that different people's compensatory mechanisms are different. So you could line up 5 patients who are hypothyroid, and they will have 5 different manifestations. Some people, their pulse, blood pressure, and all that stuff will be fine, but they really do look puffy and pale, and their hair is very thin. And then other people, their hair will look fine, and they're not puffy, but they are a little bradycardic, and you can distinctly tell that they are having mental process slowing. Everybody's just a little bit different, I guess is what I'm trying to say. So with hypothyroidism, as with many diseases, it's not like the patient just shows up and is like, oh, everything is slowing down. It's like they usually show up with a collection of vague, ill-defined complaints, half of which can just easily be attributed to normal 21st century American life, and you just have to tease them out. Like, how many patients have ever said to you, like, they feel like they're getting forgetful, or they can't remember, or their brain's just not working right? And you think, well, me too. I mean, join the club. This happens to all of us once in a while. But that can easily be an early symptom of hypothyroidism. Some people will tell you they're cold all the time. They're my favorite one. My normal temperature is 97 degrees, so when it's 98, I have a fever. Like, all of these things that, let's face it, we do tend to not take all that seriously in isolation, but they can be your early symptoms of hypothyroidism. So that's all I know about that. Actually, before we even get to treatment, oh, well, I guess it's really not for me to keep going off on these tangents. Like I said before, the most common cause of hypothyroidism is Hashimoto's autoimmune thyroiditis. What happens is the patient makes antibodies to thyroid hormone receptors, and it blocks the thyroid hormone receptor. So you remember from patho that the anterior pituitary, God, I really thought I threw this in here somewhere. But anyways, the anterior pituitary makes thyroid stimulating hormone, TSH. And then TSH travels to your thyroid gland, and the TSH binds to TSH receptors on the thyroid gland. And the thyroid stimulating hormone then stimulates the gland to increase iodine uptake and begin the synthesis of thyroid hormone. In America, the most common cause of hypothyroidism is that patients make thyroid receptor antibodies, and sometimes they are referred to as TRABs, thyroid receptor antibodies. Sometimes they're called antithyroid antibodies. Sometimes they're called antithyroperoxidase antibodies, but they're antibodies to TSH receptors, so they bind to TSH receptors and block TSH from doing its job. So now you got a patient with a thyroid gland where all the TSH receptors are bound by these thyroid antibodies. So when the pituitary releases TSH, the TSH can't do its job. It can't bind to the thyroid TSH receptors and stimulate the gland to work. So the gland doesn't work. The gland becomes hypofunctioning and the production of thyroid hormone falls. At the same time, the pituitary perceives this as the patient is hypothyroid and needs more thyroid stimulating hormone, so the anterior pituitary cranks up production of TSH. So what you see clinically is a patient who has symptoms of hypothyroidism. A little bit of weight gain, not 100 pounds, that's not thyroid disease, but like maybe a 5-pound weight gain from fluid retention, a little bit of bradycardia, a little bit of mental slowing, dry skin, like all those things we just talked about, and their TSH is elevated. That's a classic presentation of Hashimoto's thyroiditis, and if you test for thyroid antibodies or antithyroid antibodies, the titers will be present. Every lab has a different reference range for this stuff, so it's not even like I could give you like a normal versus abnormal value. You just have to compare what the lab says the patient has in terms of antibodies as compared to the reference range. But the most common cause of hypothyroidism, the one that can be very readily managed in primary care, is Hashimoto's thyroiditis, and how that presents is the patient is clinically hypothyroid, their TSH is elevated, and they have the presence of antithyroid antibodies. And so when that happens, the treatment of choice is thyroid hormone replacement. There's nothing you can do about the autoimmunity or the antibodies. All you can do is replace the hormone that the gland is unable to make on its own. So exogenous treatment, that's what this slide says, and it says there are two primary circulating types of thyroid hormone, T3 and T4. T3 is the metabolically active one. T3 is the one that does cause DNA expression of codes and stimulate gene transcription. T4, for the most part, is metabolically inactive, or I guess I should say way, way less active. Most T4 circulates in the body just waiting for the body to need it, and when the body perceives a need for thyroid hormone, it will deiodize T4, remove one of the iodines, it becomes T3, and then T3 is the one that does the job. So there is commercially available T3 and T4. T3 is marketed as liothyronine, and I believe the trade name for the brand name for it is Cytomel, Cytomel. And T4 is the one that you are probably much more familiar with. This is marketed as levothyroxine, and there are all sorts of brands of it available, like Levoxyl or Synthroid, or just generic levothyroxine or Armour Thyroid. In primary care especially, overwhelmingly, what we do is prescribe T4. So we put people on T4 and then they have it in circulation, and when their body needs active thyroid hormone, they will deiodize it to T3 and then it will do the job. Sometimes you will see endocrinology treat people who are hypothyroid with a combination of T3 and T4. But T3 is very active, and if you don't know what you're doing with it, you can put people like into a hyperthyroid crisis with little difficulty, because at least with T4, the body has some ability to regulate how much of that T4 becomes T3. Whereas if you give somebody T3, you are giving them a metabolic stimulant, basically. And endocrine can do it because they know what they're doing. This is not routinely used for good old-fashioned Hashimoto's thyroiditis, but for hypothyroidism of other causes, and there are other causes of it. I mean, Hashimoto's is the one that's most common. It's the one that we can manage in primary care, really without having to consult endocrine unless for some reason the patient doesn't respond appropriately. But there are surely other reasons why people get hypothyroid. One of them is pituitary failure. They can have pituitary failure, they can have pituitary malignancies, and then if the pituitary doesn't release TSH, then there's no TSH to stimulate the thyroid gland, so the gland doesn't make hormone. Clinically, the patient presents as hypothyroid, but we know it's not Hashimoto's because there's no anti-thyroid antibodies and the TSH is not elevated, the TSH is low. If you have a patient who presents as clinically hypothyroid and they have like no TSH or a very low amount of TSH, this isn't somebody we just put on thyroid hormone. This is somebody we send to endocrinology because there is a concern there about pituitary failure. And usually they have deficiencies in other hormones as well. So, but for us, the classic presentation, clinically hypothyroid, whether that's a little weight gain, bradycardia, fatigue, constipation, coarse skin, thin hair, the whole yard. Their TSH is elevated and they have anti-thyroid antibodies present. Then what some people will do is get a thyroid ultrasound, and you usually appreciate like sort of a diffuse heterogeneic hypertrophy of the glandular tissue because it's trying harder. Because in Hashimoto's, it's not like you get receptor antibodies that block every TSH receptor overnight. For a period of many months, the body will try to compensate and the gland will work harder, and it will sort of blow up a little bit, and you can see that on an ultrasound. But eventually, the patient will sort of crap out, become clinically hypothyroid, and then you put them on thyroid hormone. Now, what you want to put them on is T4. I wouldn't, well, I mean, I don't know. You can do whatever you're comfortable with at that point in your career. I wouldn't put somebody on T3 at this point without an endocrine involvement because it's just too labile. So for most of us in primary care, the primary issue with thyroid hormone replacement, it's not like there's much choice in drugs. You know, you just have to put the patient on thyroid hormone. And then if you try to order one brand, invariably the insurance will come back saying, that's not our Tier 1 formulary, pick something else. So you just pick whatever form of T4 is their Tier 1 formulary. And don't think you can always get by just by ordering generics, because some insurances have contracts with a brand manufacturer, and you'll find that if you try to order something generic, figuring you're, ordering the cheap stuff and trying to save yourself a headache of a prior auth, it'll come back and deny it. Like if you order levothyroxine, but the insurance company has a contract with Synthroid, you have to order it as Synthroid. This is part of the master conspiracy to always make you do a PA no matter what is going on. But anyways, you're going to order T4, and the primary issue is how much the patient needs. So if, remember, the patient is clinically hypothyroid, and we are trying to replace approximately what the body would do if it could. Thyroid hormone is replaced as T4, and the average adult requires 1.6 mics per kilogram per day. That's why it's like no mistake that there is a 112 microgram thyroid pill, because the PDR thinks we're all 70 kilogram males, and if you were 70 kilograms and you needed to replace 1.6 mics per kilogram per day, you would need a 112 microgram dose. Not everybody with Hashimoto's immediately has the gland crap out, so you may not have to start the patient at 112, or 112 mics may not be your goal. That's just the average requirement of thyroid hormone for the average garden variety adult. So basically, you calculate what you think they need and then start at about 50% that dose and titrate up very slowly. And if the patient is just a little bit symptomatic and their TSH isn't that high, maybe it's like 5 or 6 or something, you can start them on 25 mics a day and then reassess them in 8 to 12 weeks. I mean, most people like this didn't become hypothyroid overnight, and it's not going to get better overnight, so there's no compelling urge to immediately nail this right away. If you're ever unsure about the dose of thyroid hormone you're giving, just start low and go slow. You know the mantra. Just as a point of interest, elderly adults, they're less metabolic. Their metabolic rate is slower, so they need less. So if you are diagnosing hypothyroidism in an older patient, and again, what defines older, I don't know. It's a really generic term, and you just have to decide for yourself. I mean, 65 is one term people use to define elderly because I guess it's Social Security age. I don't know. I remember once upon a time, the American Nurses Credentialing Center, when they had a separate gerontological nurse practitioner certification exam, they defined the geriatric patient as anyone over 55, whereas the AAMP defined it as anybody over 65. So I don't know, but older. As we get older, our metabolic rates slow down. This is evidenced by the increasing accumulation of belly fat as we get older. So if you're starting thyroid hormone replacement on somebody certainly over 65, you know that they only need about 1 mic per kilogram per day. And so they're going to need less. Children, on the other hand, and like that says on the slide, I am not implying by any means any of us should be managing pediatric hypothyroidism. That needs to go to a pediatric endocrinologist because they have so much going on in the way of growth and development. They have to be managed right to grow properly. So if you have any suspicion that a child is hypothyroid, you just want to send them right on to pediatric endocrinology. But you'll find that they will come back to you on what looks like high doses of thyroid hormone comparatively, because they get 4.0 mics per kilogram per day, because they are like little metabolic machines. You know, they're just growing and growing, and everything's developing. So they do need more thyroid hormone. This dose will slow down as they get older, as they reach adulthood. Just as a rule of thumb, remember that thyroid, when you replace exogenous thyroid hormone in the form of levothyroxine, it tends to bind very easily to anything else that's in the gut. So the patient is supposed to be instructed to take their thyroid hormone on an empty stomach, separated by anything else they eat that day by at least 2 hours, with a full glass of water. I totally get that this is easier said than done. Like, a lot of people get up and they eat, you know, basically right away before they go to work, and they don't have time to get up, take a pill, and then sit around for 2 hours before they eat and go to work. And then once you've eaten, if you've eaten, you need to have the stomach, you know, let the stomach get some time to be empty before you put thyroid hormone in it. A lot of people come home from work and eat their biggest meal in the evening, and then aren't up all that much longer before they go to bed. So the most important thing with thyroid hormone is that it be taken on as empty a stomach as possible, and consistently at the same time every day. So you just, you know, try to figure out with your patient what's the best time of day. If you find that you put them on thyroid hormone and they're not responding to it, their TSH isn't going down the way you would expect, chances are they're probably taking it with something that binds it in the gut and interferes with absorption. And then finally, remember that thyroid hormone, the body really takes time to adjust to new doses or a change in dose. So there is just no reason to check a TSH any sooner than 8 weeks after starting it, and you're really probably better off to wait closer to 12 weeks. So you start a patient on thyroid hormone in January, March, back at the end of March, beginning of April for a TSH to see what's going on. If you do it too soon and you start adjusting the dose too soon, they're just going to be all over the place with their TSH. Better to let it go a little bit and you know, take longer to get things under control. And that's all I know about hypothyroidism, I guess. Hypothyroidism, or at least hyper. We actually do have more to talk about in terms of drug therapy with that. So just a definition here to begin the conversation. Thyrotoxicosis is what the patient is experiencing when you think of them being clinically hyperthyroid. When you see a patient that has symptoms of a thyroid hormone excess, they may or may not be hyperthyroid, but they are thyrotoxic. Thyrotoxicosis just means there's too much thyroid hormone on board, so they have clinical evidence. They're basically hypermetabolic, right? Now they've got enough hormone that their gene transcription is too fast and body systems are moving too fast. It might be because they are hyperthyroid, which strictly defined means that the gland is actually working at an exaggerated fashion. Or they might have too much thyroid hormone on board for other reasons, like their dose of levothyroxine may be too high. So it's not that their gland is hyperfunctioning or hyperthyroid. They're thyrotoxic because they're taking thyroid hormone, too much thyroid hormone. Some people that don't have thyroid disease will take thyroid hormone because some knucklehead told them it will help them lose weight or make their skin look good or whatever. Some people are legitimately taking it and they're taking too much. You know, a lot of times if you prescribe stuff for people and they feel better when they take 1 pill, they might think 2 pills is even better and take it. Or maybe they were taking it on an empty stomach, And then they changed their deal and started taking it, or they were taking it on a full stomach, and then they changed up and started taking it on an empty stomach, so they're absorbing it a lot better. So there's lots of reasons that patients can be thyrotoxic without having a hyperfunctioning gland. Thyrotoxic, too much active thyroid hormone for any reason. Hyperthyroid, they have too much thyroid hormone because the gland itself is hyperfunctioning. So here is the gland. Okay, so let's see, what do you got? So this is the thyroid gland, and this is the membrane, just like any other membrane. If you looked at it up close and personal, it would have hydrophilic heads and hydrophilic tails. In here, embedded in the membrane, is this protein pump. And in this case, it's an iodine pump. It pumps iodine from peripheral circulation into the thyroid gland. Remember that the thyroid gland is the only gland in the entire body that uses iodine. So virtually all iodine that you ingest gets pumped into this gland via these iodine pumps, which actually are all over the place here. You only see one. So then the iodine gets pumped into the thyroid follicular cell. At the same time, in the cell, it's got a nucleus, not visioned here, but this is a cell. It's got all the same organelles as every other cell. And one of them is the rough endoplasmic reticulum that performs protein synthesis. And in the thyroid gland, it makes thyroglobulins. So you make your thyroglobulin and you pump in your iodine. And as it gets pumped deeper into the colloid of the thyroid gland, the thyroglobulin has tyrosine in it. And this gets complexed with iodine by way of iodination, and then you wind up with thyroglobulin complexed with iodine, which is a T something, T1 or T2. And then if it has one iodine, it's T1. If it has two iodines like this one does, this is thyroglobulin with diiodotyrosine, T2. You pump together a couple T2s and it makes a T4. Pump together a T2 and a T1 and it makes a T3. These are moved back into the thyroid follicular cell and stored here. And they're stored, the thyroglobulins, with either 4 iodines or 3 iodines. There's a bunch of them. And they get stored here and they wait until their release is stimulated out into peripheral circulation. And then the gland will release T3 and T4. Mostly T4. If you look at all the hormone that the thyroid gland releases, it's about 90% T4 and only about 10% T3. Remember, T3 is active and T4 is considered metabolic storage. Anyways, they go out into circulation and do their thing. So the reason I even mention this is that some of the drug therapies that we use will interfere with some of these processes. But this is how the hormone is synthesized, and the thyroid gland excuse me, is the type of cell that stores its hormone. Some hormones, like steroid hormones, are released as soon as they are made. There's no storage about it. But the thyroid gland is capable of storing up to about 3 or 4 months of hormone in the gland. In these little storage things here, little vacuoles. So, and there it stays. So the reason I mention that is one of the causes of hypothyroidism, well, shoot, I just said the wrong thing. One of the causes of thyrotoxicosis is that something insults or inflames or stimulates the gland and it dumps all of the hormone out at once. So again, it's not that the gland is hyperfunctioning, the gland is functioning just fine, but something happened and all this hormone got shoved out into the body, so the patient will be clinically thyrotoxic. So this is just a reminder. I mentioned this before. You have the pituitary gland that releases TSH. This, I didn't mention this, but you probably know that TSH is stimulated by thyroid releasing hormone from the hypothalamus. You have the hypothalamic stalk where the hypothalamus communicates with the pituitary gland and stimulates the release of a bunch of stimulators, basically. But relative to our conversation, thyroid releasing hormone stimulates the pituitary to produce thyroid stimulating hormone, and then thyroid stimulating hormone binds to TSH receptors, the TSH receptors on the thyroid gland, and that stimulates the gland to start producing and storing T3 and T4. It will also make calcitonin. This is a multifaceted cell. Remember, calcitonin is one of the hormones of calcium storage in bone. But we're interested in T3 and T4. So thyroid stimulating hormone binds to a thyroid stimulating hormone receptor and makes it make all this hormone that eventually will get released into peripheral circulation. Remember, I said Hashimoto's thyroiditis occurs when you have an antibody that blocks this receptor so that TSH cannot bind to it and stimulate the gland. And that's Hashimoto's hypothyroidism. Conversely, we also have a form of the only really true form of hyperthyroidism, which is also autoimmune mediated, and that is Graves' disease. In Graves' disease, just like Hashimoto's thyroiditis is the most common cause of hypothyroidism, Graves' disease is the most common cause of thyrotoxicosis, or too much thyroid hormone. And this is also an autoimmune disorder. And what you've got now aren't anti-thyroid antibodies. You have thyroid receptor antibodies that stimulate the gland. So we get these thyroid antibodies. They're actually referred to as TSIs, thyroid stimulating immune globulins, and they stimulate TSH receptors as if they were TSH. So the gland is truly hyperfunctioning, and this is autoimmune. These TSIs are autoantibodies. Also, your handout says that Graves' disease may be accompanied by Graves' ophthalmopathy, and that's true. And this is the only thyroid excess phenomenon associated with ophthalmopathy, and it's because people who have autoimmune TSIs also sometimes have autoimmune ocular muscle antibodies, and it causes hypertrophy of the ocular muscles, and that's why they get ophthalmopathy. People who have thyrotoxicosis for other reasons, like taking too much levothyroxine, they don't get ophthalmopathy. Only people with Graves' disease get it as a consequence of their hyperthyroidism. People who are thyrotoxic due to Graves' disease, usually it tends to really be severe. This is one of the more clinically severe forms of thyrotoxicosis, and it is not transient. It needs to be treated definitively. So here's the deal. Oh, look, I made a picture. I was feeling creative. So in Graves' disease, you have these thyroid stimulating immune globulins. They act like TSH, and they stimulate this receptor antibody. It's not TSH. They're antibodies that act like it. So they stimulate the gland, so the gland hyperfunctions. The feedback to the anterior pituitary is, we don't need any more. The gland is hyperfunctioning. We have plenty of thyroid hormones. Stop making TSH. So the pituitary will stop making TSH, and if you measure the patient's TSH levels, it will be too low. But it doesn't matter because it's not TSH that's doing the job, it's TSIs. So a patient with Graves' disease will have clinically relevant thyrotoxicosis, tachycardia, hypertension, weight loss, heat intolerance, all of that kind of stuff, and their TSH will be low. And if you do a serum assay for thyroid stimulating immune globulins, they will have it. So pharmacologic treatment of Graves' disease, there's both symptom control and definitive treatment. Usually by the time you see these patients, they are symptomatic. They are presenting with generalized signs and symptoms of hypermetabolism. They may be tremulous. They may be having trouble sleeping. They may be experiencing unplanned weight loss. They may have anxiety. They may have like tachycardia and even a little bit of angina or palpitations. Blood pressure is usually, above goal. They tend to have beautiful skin though because their dermal turnover is exaggerated. They tend to not be constipated. They usually have bowel hypermotility and will have a couple of low volume loose stools every day. And women, they tend to report very light scant periods because even endometrial shedding it happens quickly. It just doesn't take long. So there are some advantages to having Graves' disease, but I guess they're not offset by the metabolic consequences. Anyway, that presentation is usually symptomatic. And again, everybody compensates differently. So The symptom presentation isn't necessarily the same for two different people. But the bottom line is that the drug of choice for symptomatic treatment is a non-cardioselective beta blocker. Propranolol is the classic textbook. This is Inderal, and this is the prototype non-cardioselective beta blocker. It blocks beta stimulation virtually all over the body. So it can slow down everything: the heart rate, the blood pressure, the central nervous system excitability, the agitation, the tremor, the sleeplessness, the bowel hypermotility, all of it. Every now and then, you will see people prescribe a cardioselective beta blocker for Graves' disease, and I don't know why. I can't answer that unless the patient has really brittle or unstable asthma and they're just afraid to have them on a non-cardioselective beta blocker for that reason. Then they might put them on a cardioselective beta blocker just to try to control the cardiovascular symptoms of Graves, because obviously they're potentially among the more dangerous ones. But unless the patient has a contraindication to a non-cardioselective beta blocker, propranolol really is the drug of choice for symptomatic relief. But then they need to be referred for a definitive treatment. The gland, this thyroid stimulating immune globulin thing is not going away. The patient needs definitive treatment. So unlike Hashimoto's, where you can just put the patient on levothyroxine and monitor them in primary care, patients with Graves' disease need to be referred to endocrinology. They're going to need a curative intervention. So really the thing to do, once you confirm this diagnosis by lab testing of a clinically thyrotoxic patient whose TSH is suppressed and has thyroid-stimulating immune globulins, that's Graves. Put them on Inderal for symptom control and refer them to endocrinology. And then endocrinology will evaluate and refer them for definitive treatment, which usually is radioactive iodine, radioactive ablation of the gland. Because in this case, the whole gland is hyperfunctioning, and all there really is to do is to ablate it. So remember that iodine, that the thyroid gland is the only gland in the body that iodine gets pumped into. So what they do is calculate the right dose, and then they give the patient radioactive iodine, knowing that it will all be trapped in the thyroid gland, and it ablates the gland. It decreases the functional mass of the gland. Many times afterwards, patients come out clinically hypothyroid and have to go on thyroid hormone replacement for the rest of their lives, but at least that's controllable. So radioactive ablation is usually definitive treatment. The last bullet point here says certain patients should be pre-treated with anti-thyroid drugs. And again, this isn't typically our call in primary care. This is something that endocrinology will decide. Those patients who are extremely symptomatic, or those who are very vulnerable to the cardiovascular consequences of Graves, like people with pre-existing heart disease, old MI, congestive heart failure, stuff like that. Anti-thyroid drugs are those drugs that PTU and Tapazole, you would probably know them as. All they do is block the conversion of T4 to T3. So they decrease the metabolically active thyroid hormone in circulation. And it's sort of a short-term way to decrease productivity of the gland pending definitive treatment. But again, that's really a decision of endocrinology. Let's see, not everyone is a candidate for RAI, radioactive ablation, and that's true. Patients with mild forms of disease, which honestly you don't see a whole lot of. Like I said, Graves tends to be a little bit more extreme in its presentation, but if the patients, because radioactive ablation is a big deal, some patients just don't want it, even if they're counseled to take it. And so those people, or people with milder forms of disease, sometimes are just treated with anti-thyroid drugs, Tapazole and PTU. I can't believe I didn't put them in your handout somewhere. Sorry about that. The names of the drugs should probably be here. But they're old drugs, and they're rarely anybody's first choice anymore because they're controller. They're not definitive treatment. Radioactive ablation is the definitive treatment. And the only time you would prefer to use anti-thyroid drugs is if the patient is not a candidate for radioactive ablation, like the patient is pregnant, or maybe the patient is like really elderly, or it is a very mild form of Graves' disease. So for all of those reasons, you just put them on PTU or tapazole and try to decrease the hyperactivity of the gland. Surgery is the treatment of choice in pregnant women with Graves' disease who don't respond to PTU. So if you're pregnant, the first thing, if they're going to do it again, we don't do this alone, we would do this in conjunction with endocrinology and probably OB. If a patient is pregnant and they develop clinically relevant Graves' disease, the initial intervention is an antithyroid drug like PTU. And, these are like category D drugs, I think. I mean, it's no joke. This is why we want to do it in conjunction with somebody who's not us. But if they don't respond to PTU, Graves' disease can be really dangerous on the developing fetus because it's hypermetabolic. So sometimes they do need to surgically debulk the gland, but I don't know. I'm sure that doesn't happen very often. Okay, I was going to say something else, but I'm trying to rein in my tangents here. So that's Graves' disease, and that is the most common form of thyrotoxicosis and among the more severe. Okay, another form of thyroid hormone excess or thyrotoxicosis is autonomous thyrotoxicosis. These are when patients have nodules on the gland that are referred to as hot nodules. In other words, they make a bunch of thyroid hormone on their own initiative, like without the stimulus of TSH. They are just they're autonomous. They don't have any trigger to produce this thyroid hormone. There might be a single adenoma. This is an autonomously functioning thyroid nodule, or multiple nodules known as toxic multinodular goiter. These are not autoimmune. There is no thyroid receptor antibody or TSI. It's just the nodules, these little nodules grow and they're little TSH factor or the little thyroid hormone factories, and they just produce thyroid hormone. Like your handout says, this is generally a slower disease, not as quickly to present or decompensate as Graves. And for whatever reason, cardiovascular symptoms tend to predominate here. Maybe just because it presents faster, or slower rather. The treatment of choice for these, let's see. And there you go. There's a picture of a nodule. So unlike Graves, where the whole thing is stimulated to go into overdrive, this you got a normal gland with a little nodule on it. The treatment is to cut it off. Let's see what your slide says. Treatment depends upon clinical status. Well, okay, yes, that's true. If the patient is clinically euthyroid, like they're not symptomatic, then you just observe. Of course, if the patient is not symptomatic, you're probably not going to find the nodule anyway. I mean, theoretically, if you do a really good physical exam and you palpate the patient's thyroid gland, you could palpate a thyroid nodule. Perhaps some of you listening have. I never have. Of all the thousands of thyroid glands I've palpated over the years, I've never palpated something and thought, "Oh, that feels like a nodule. Let's scan it and see what's happening." I have had patients come to me and say, "Hey, I feel this lump in my neck. What do you think about this?" And then I'll feel it where they tell me to, and then I'll feel a nodule. But I've never found one on my own. And so if you happen to find one, or the patient finds one, but they are clinically euthyroid, no tachycardia, hypertension, weight loss, blah, 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 yes, then it is appropriate to clinically observe. But if the patient is symptomatic, what does your handout say? I want to match your handout, even though the answer is surgery. The symptomatic patient will require definitive treatment. These do not respond spontaneously. Treatment depends upon several variables. Doesn't it always? Let's see what your next slide says. I guess I should be quiet till I read it. Oh, wait, this is toxic multinodular goiter. I can't back up to your last slide, but the last slide was about autonomous thyrotoxicosis. This is generally a single nodule treatment, single nodule phenomenon, and the single nodule treatment for a clinically relevant or clinically thyrotoxic single nodule is surgical removal of the nodule. So your slide doesn't say it, but I hope you'll trust my judgment on that one. If you don't, you can Google it and you'll see. Yes, clinically euthyroid, not symptomatic, leave it alone and monitor them. But if they are clinically symptomatic, the nodule just needs to come out. Now, toxic multinodular goiter is different. That's what this slide is talking about, because there's a lot of nodules here. So this is like basically the whole gland, or at least the biggest part of it, is full of nodules, so it's harder to cut them all out. So like Graves' disease, radioactive ablation is the treatment of choice in symptomatic patients. The dose, like your handout says, is even typically higher than Graves because in Graves' disease, the gland is hyperfunctioning. In toxic multinodular goiter, you've got a whole slew of nodules that are just totally independent of any feedback mechanism. They're just slamming. These patients do tend to be very symptomatic, and radioactive ablation is the drug of choice. And of course, if you're first seeing them and they are symptomatic, you put them on propranolol. Propranolol is the one constant for any form of symptomatic thyrotoxicosis. If the patient is symptomatic, put them on propranolol until they get to endocrinology, who figures out the cause of their thyrotoxicosis and then treats it. So these patients, once they get to endocrine, they are often pre-treated with antithyroid drugs like Tapazole and PTU. Low iodine uptake, even, to try to facilitate the uptake of this radioactive iodine. And like the last thing your handout says, surgically only an issue typically when this is cosmetic or pressure against the trachea. If you Google images of toxic multinodular goiter, I mean, you'll see what some of these necks looks like. There's just so many nodules, it's like the patient can hardly even breathe, not to mention put clothes on. So here you go. Look at all. I mean, so here's like a normal one. And then look at this. The thing is gigantic, and there's just nodules all over the place. And then finally, in terms of causation, we have subacute thyroiditis, also known as de Quervain's. I guess it's the same de Quervain that did tenosynovitis. Anyway, subacute thyroiditis is the condition where the gland is not overstimulated. There's nothing wrong with the gland except it got inflamed and it dumped out all of its hormone at one time. So this is the one I was talking about where the gland like stores 3 to 4 months worth of hormone in it, and something happens to insult it, usually a virus, and it just dumps all of its hormone out. So for a relatively brief period of time, the patient appears thyrotoxic. This is not autoimmune. This is not a nodule. This is not a goiter. This is nothing except that the gland just got inflamed, dumped out all of its hormone, and all you do is just wait for the person to metabolize that hormone, excrete it, and then go back to normal. These patients tend to be not as clinically symptomatic, and lots of times you can just follow them. But again, if you have to treat it, propranolol. Just treat the symptoms until they metabolize the hormone excess and return to normal. These patients typically, when you palpate their neck, it hurts. The gland is inflamed. You palpate their thyroid gland and it's uncomfortable. And they're usually just mildly thyrotoxic, and then after a few months it will go away. This is everything I just said. It's self-limiting. All you do is treat symptoms with a beta blocker. No other therapies are indicated. Like, you don't want to ablate this gland because it's not hyperfunctioning. In 3 months or so, once the spilled hormone is metabolized, the gland is back to its normal function. All right, so there's a few slides here about the drugs. Beta blockers, like I said, these are pretty much the one constant. Propranolol is non-cardioselective, atenolol is cardioselective. There may be reasons, I don't know. I mean, I'm no endocrine expert, but I can't think of any reason not to give the patient a non-cardioselective beta blocker unless they have a contraindication to the non-cardioselective beta blocker. These drugs have no curative properties at all. These are just symptom control. Stop the drug, it goes away. I mean, this is just symptom management while somebody treats the problem. Now, I've alluded to radioactive ablation a few times, and that's not what the iodides are. Radioactive ablation is radioactive iodine. It's calculated and done by interventional radiology, and it's a big deal, and usually it's just one dose, and you ablate the gland, and that's it. But there are lots of forms of iodides available. Lugol's solution is probably a name that you will recognize, and the role of Lugol's solution, or the iodides, is that it's kind of counterintuitive, but if you keep in mind that the thyroid gland is the only gland in the body that actively pumps iodine from peripheral circulation into the gland, usually it's really a struggle. Like usually we have to take, iodized salt or something, like some sort of iodine supplement, because there isn't that much iodine in our diet. And so the gland functions just fine. It's the thyroid gland is built to capitalize on that and take every piece of iodine you've got and pump it into your gland. When you give somebody iodides, these are very high concentration of iodides, and you basically bombard the thyroid gland with iodine, and what it will do is downregulate iodine receptors in order to protect itself. So you give somebody Lugol solution. The gland is like, yo, I'm totally overburdened here with iodine. The gland is afraid it's going to have to hyperfunction, so it will basically shut down production, and it very quickly decreases vascularity of the gland, decreases production of thyroid hormone. Iodides inhibit organification, which is the iodination of tyrosine in the thyroglobulin with iodine. It inhibits that and inhibits proteolysis, which is kind of the cracking and release of the new hormone. So, and it inhibits peripheral deiodinization. So giving high-dose iodides like Lugol solution really slams down thyroid gland function quickly. It's not meant to be like a lifelong treatment. I think the next slide has some more info about it. Yeah. Useful for patients who are particularly toxic because it can hop in there really fast, and is an augment therapy, blah, blah, blah. Can be used actually for a period of months if necessary, but this is, again, not meant to be a long-term management, and it usually isn't used for several months. I think this is most commonly used to decrease the vascularity of the gland before operation. So it's really a short-term intervention. Lugol solution, and there's others too. I just took their names out of here to make the slide fit. Finally, the anti-thyroid agents, I had alluded to them once or twice. Propylthiouracil uracil is PTU, and methimazole is, there should be an O there, Tapazole, sorry, Tapazole. And these are the most common, and like I said, they inhibit organification, they inhibit coupling, they inhibit really all forms of the activity of the gland. And they're not anybody's drug of choice because they are just controller, they're not curative. This bullet point says opinions on recurrence once the drugs are DC'd vary. There are those who say that if you give this long enough, it can, like, quote, cure Graves' disease, but most of the literature does not agree with that. Most of the literature says these are not a first-line option. These are used in pregnant patients, these are used in very mild disease, and they're used when patients need a curative form but don't want it. A lot of people really hesitate for radioactive ablation or hesitate for surgery on their neck, and then while they're waiting, you can use the anti-thyroid drugs. And then finally, radioactive iodine, and this is how you ablate the gland in Graves' disease. And I think everything here probably wouldn't be a surprise. Again, capitalizes on the iodine trapping. Yeah, there's all sorts of, there's all sorts of guidelines. I mean, it is radioactive, so there are guidelines about, for how long you avoid close contact, pregnancy, like what happens to the waist, etc. But this is all really managed by interventional radiology. So that's all I know about that. Now we have a couple slides on some other hormonal things, which I am going to come back and do in a little bit. So I have to turn off my pointer, turn off my thing. See you in a few minutes for adrenal pharmacology. Okay, so time to finish up this topic here. The next couple of topics, I don't have as much to say about them because, frankly, I don't know as much about them, but I figure as much as I know is probably enough to get us started in primary care, and then if you wind up working in the specialty of endocrinology, you can come back and teach the rest of us. But topic now is adrenal pharmacology. So, you have your adrenal gland, and it's got 3 zones that produce basically 3 hormone groups, right? The glucocorticoids, the mineralocorticoids, and the androgens. So the mineralocorticoids, the most clinically relevant one is aldosterone, and aldosterone is the hormone of salt retention. Some people have adrenal dysfunction, and I'm resisting the urge to go into that here. Hopefully you talked about it in patho, and if you didn't, you'll talk about it in your clinical courses. But some people do have adrenal dysfunction and they don't produce enough aldosterone, so they do have a defect in their ability to retain salt. Usually this isn't the primary problem. This is known as Addison's disease. It's adrenal hypofunction, and more often the patients have cortisol problems, and you only really see aldosterone deficiencies when they are under times of extreme physiologic stress. Because remember, all of these hormones are stress hormones. The adrenal gland is a hormone of stress response. You have the adrenal cortex, which is what we're talking about here. Then you have the adrenal medulla. The adrenal medulla is the area that makes like epinephrine and norepinephrine, your primary fear, flight, fight stress hormones. And then the adrenal cortex makes the secondary stress hormones, the ones that keep you in the fight after epinephrine gets there. So aldosterone as a hormone of salt retention, this is really important because salt is the primary sodium is the primary extracellular solute. So it is more responsible than any other single electrolyte or solute for that matter, for keeping water in the vasculature, for maintaining intravascular volume. If you lose the ability to produce aldosterone, you lose your salt retaining ability, you lose all of your salt in the urine, and you will get very hypovolemic very fast. The primary symptom of a patient with an aldosterone deficiency are symptoms of decreased sodium and water retention. They are hyponatremic, they are hypovolemic, they're usually hypotensive, and remember, whenever you are hyponatremic from a kidney problem, you will become hyperkalemic. So anyway, the problem with a natural deficiency in aldosterone is you can't retain enough salt. Cortisol is the most clinically relevant glucocorticoid, and cortisol, so we administer this as prednisone and Solu-Cortef, and you're familiar with this. Cortisol is also a secondary stress hormone. It is responsible for the utilization of fuel sources because you need to burn your you need to burn your food to fight a stressor. Oh, it's time for this semester to be over, isn't it? Burn your fuel. Burn fuel. You have to be able to burn fuel sources to make your cells make energy. Cortisol, also as a secondary stress hormone, will maintain vasoconstriction to keep your brain perfused with blood. It suppresses inflammation because you can't be all inflamed when you're trying to fight a stressor. If you are trying to sustain a fear, flight, fight response, which is what cortisol wants to help you do, it does stuff like, you don't feel inflammation in your joints, you don't experience inflammation. And then finally, androgens are the precursors of testosterone. So you have to have your sex hormones, because if you don't have your sex hormones, you can't reproduce and perpetuate the species. If you don't have your sex hormones, you won't become sexually mature. So if you're a man, you won't grow a beard, and if you're a woman, you won't grow breasts and ovulate, and you won't grow axillary hair and pubic hair and all that other hair that we shave off anyways. But that's what androgen does. So this gland releases all of those hormones. And the pharmacology of managing this system is really about replacing these hormones in the deficient patient. A condition of aldosterone excess is most unusual. It is an adrenal tumor called Conn's syndrome. And if you have this tumor and produce too much aldosterone, the treatment is to surgically remove it. If you have too much adrenocorticoid, like too much cortisol, if you have Cushing's syndrome, then it's usually from a tumor, and the treatment is to remove the tumor. And if you can't, you just control the symptoms of the excess. There's no drugs to cure this, like there are drugs, say, to cure Graves' disease. And if you don't have enough androgens, we just replace them, by giving hormone, whichever hormone you're deficient in, we replace it. So the pharmacology of the adrenal gland is really about replacing hormones that are deficient. So the most common forms that you will prescribe are fludrocortisone. This is marketed as Florinef, and this is what we give patients who are clinically deficient in aldosterone. And like I said, it's usually not like something on the day-to-day. When people have an adrenocortical insufficiency, which is Addison's disease, usually the hormone we have to replace every day is the hydrocortisone. the fludrocortisone only really becomes evident like if they get really sick. Like years ago, when I was first a nurse practitioner, I used to have this patient who's like a cat with 9 lives, I swear, and he had Addison's disease, and so he was maintained on cortisol replacement every day. And then whenever he lived in a long-term care facility, whenever he would get like sick, like with pneumonia or something, then his fludrocortisone, his aldosterone would tank out, and then he couldn't retain any water, and he'd get like seriously hypotensive and have to come in the hospital. And then we would fix the problem, which was usually sepsis. He was an older guy. It was either a UTI or pneumonia most of the time, and replace the aldosterone with Florinef until he got better, and then his adrenal gland could at least make enough to get him by. So fludrocortisone is marketed as Florinef, and that's usually replaced transiently. Only once in my life have I ever seen a patient maintained on it for the long haul. I mean, I'm sure if you work endocrine, you'll see more than that. But I've only ever seen one patient that had to take it every single day because of a serious deficiency. And hydrocortisone, which again is marketed as prednisone or Solu-Cortef, this is how we replace the glucocorticoid in patients who have Addison's disease. And it's not like, I mean, I know you probably are getting the impression that you have to be really careful when giving patients prednisone, for instance, when you give them steroids, because you don't want to suppress their own adrenal gland. And like when we give them supraphysiologic doses for things like asthma, or sepsis, or like rheumatoid arthritis, or whatever the case may be. It's true, you have to be careful in suppressing adrenal function in those patients because they do have adrenal function. We're trying to make them supraphysiologic. But in a patient with Addison's disease, they're not making enough hydrocortisone. So when we give it to them pharmacologically, we're just replacing what they can't produce. So it's a little bit different. It's different than giving prednisone to a healthy patient like you or me. And remember also that when you replace hydrocortisone, we try to do it the way that the body would do it if it could. And hydrocortisone or glucocorticoid is a diurnal hormone. Your body releases more of it in the morning and then it wanes during the day. So when we have somebody with Addison's disease on prednisone replacement, it's usually a larger dose in the morning and then a lesser dose later in the afternoon. And a very typical starting combination is 15 milligrams in the morning and then 10 milligrams later in the afternoon. All right, so fludrocortisone, which is the pharmacologic version of aldosterone, it is the hormone of salt retention. It makes the kidney retain salt. And it is very potent. A really standard dose is like 0.05 milligrams 3 times a week, and you're just titrating it to sodium retaining effect. It's basically as soon as they even begin to look like they have a fluid excess, you want to stop it. And this is really this is a real profound response. Like, it's the best way I can describe it is in these patients, it's almost like they're a sponge that's suddenly filling up with water. When you first see them, they're all dried out and they're all volume contracted and stuff, and then you give them a little fludrocortisone and they just kind of fill out. You know, they just sort of hydrate and fill out. And as soon as their blood pressure starts to like bump the upper limits of normal, or they have edema or any indices of fluid retention, then it's time to back off on the fludrocortisone because it happens really fast. And again, you're giving them a hormone that will make them retain sodium. That means if it's not balanced properly, they're going to be hypernatremic, and then in an effort to compensate, the kidney will give off potassium, so they will become hypokalemic. Hypernatremic and hypokalemic is in combination is a patient with too much aldosterone on board. Unless they're on diuretics, and that's a whole different story. Hydrocortisone. So this is just synthetic prednisone, so it does all the things that prednisone will do. It will cause vasoconstriction, which is good unless you have too much of it and then you get hypertensive. It will mobilize fuel sources, which is good unless you do it too much, and then the patients will get hyperglycemic. And it will suppress the ability to inflame, which is a good thing unless you overdo it. And then you can't mount an inflammatory response and you can't heal. So these are all the symptoms of a hydrocortisone or prednisone excess. Elevated blood pressure, elevated blood sugar, and no ability to heal. Rashes and sores that won't go away, recurrent yeast infections in women, stuff like that. So that's all I have to say about that. And then the last thing I have a few slides on is hormone therapy or hormone replacement therapy. Honestly, I'm not sure what's the politically correct term right now. Oh, whoops. There was one more slide. But this is everything that I just said. And yes, the last bullet point here says adrenal suppression can occur with long-term use, assuming that the patient has adrenal function. Like if you have a patient on, like a good one is temporal arteritis. You know, this is an autoimmune disease where the, what do you call it? The temporal artery gets inflamed, and you have to have patients on prednisone, like 60 milligrams a day for 2 months. That's a lot of prednisone. Excuse me, that's a lot of prednisone. Now that patient has a totally fine adrenal gland, so if you start giving them an additional 60 milligrams of prednisone a day, it will, yes, suppress their adrenal function, and if you withdraw that prednisone suddenly, they will go into an Addisonian crisis. Take it from one who knows, take it from one who did it to a patient before I fully understood this. So if you have a good adrenal gland, like I said before, and you are managing the patient with a high dose steroid for some other reason, yes, you have to taper it down. But if they have Addison's disease and they're not making any cortisol anyways, then you're not going to suppress the adrenal gland with long-term use because the adrenal gland is already suppressed, which is, why you're using it in the first place. So that's my point of clarification for that. Okay, now the last topic of conversation is hormone replacement therapy. And I put replacement in parentheses because I think the most appropriate terminology is hormone therapy, because we used to call it hormone replacement therapy, and then all those studies said that it could not be a good thing. And just in order to sort of remarket it and pre-package it, they started calling it hormone therapy instead of hormone replacement therapy. So anyways, this, whatever you call it, this is replacing estrogen and or progesterone in a postmenopausal woman. So, oh, phooey, I had, well, let me advance the slide. I had pulled up a few websites because I wanted to read some things to you, and then I forgot that when I'm recording the PowerPoint, I can't put anything else on my screen, so I'll just have to try to remember. But so hormone therapy, like the slide says, initially was instituted in women for menopause, and the very profound vasomotor symptoms were the primary symptoms that women wanted to medicate. And this was, I think the concept was first started in the 40s. And some of the pharmaceutical companies started marketing estrogen and progestin replacement so that women could reduce the symptoms of menopause. And then in 1996, a British gynecologist named Dr. Robert Wilson, I'm going to see if I can link one of these publications to your readings for this week. This lunkhead named Dr. Robert Wilson from Britain was hired by a pharmaceutical company. I believe it was Glaxo Welcome or whatever it was called then, and they wanted him to market and encourage women to take hormone therapy. And so he wrote this book called Feminine Forever, and then went on a book tour and convinced women to take hormone therapy. But his position was, and I wish I could see these so I could read them to you now, but I will link them. This is just for a good laugh, nothing else. Dr. Wilson's theory was that women should take hormone therapy because he described menopause as a state of living decay in which a woman's body as well as her mind deteriorate. And he talks about how the breast and the vagina shrivel up and how the bones fall apart and how women's minds deteriorate and they become all bitchy and stuff. And he and his wife actually went around touring and lecturing to convince women to take hormone therapy, basically so that they wouldn't decay and they would remain worthy of their male counterparts who did not experience a sudden loss in hormones. And he even went on to say that it was perfectly acceptable for men to have affairs if their wives go through menopause and won't take hormone therapy, essentially because their wives are not worthy of them if they don't have their sex hormones. So the guy is just a total idiot. But for the time, listen, having lived through it, I will agree sometimes that menopause does feel like a state of living decay. But that is no reason to advocate that your husband's have an affair if you won't take hormone therapy. So I'm going to try to link some of this stuff to your reading. It's just a freaking riot. Of course, we now know that living decay notwithstanding, Hormone therapy is not advocated for this purpose, but we do know that it can absolutely decrease the incidence of vasomotor flushing. And it is true that when you replace estrogens, some things don't shrivel up because it really just comes down to physiology. If you look at the female body from a purely physiologic perspective, the purpose of the reproductive genitalia is to reproduce. So when you reach menopause and your ovaries no longer produce estrogen and you are not capable of releasing follicles and you can't reproduce, then the reproductive genitalia is not designed to receive, I guess is the best way to put it. And so, stuff does change. And hormone therapy can improve that. I mean, all of the things that happen with estrogen loss, when you don't have any estrogen, you don't have any lactic acid. When you don't have any lactic acid, the vagina, the reproductive genitalia becomes sort of dry and easily friable and susceptible to, say, friction burns, like just between you and me. If you have a couple and the husband asks you for Viagra, offer the woman at least topical vaginal estrogen, because in a month she's going to come back complaining about abrasions in her vagina. Absolutely, after menopause, things change. But Dr. Wilson's take on it just wasn't very popular. Anyway, among other things, when they were first looking at hormone therapy decades ago, retrospective data also suggested that hormone therapy could reduce the incidence of cardiovascular morbidity and mortality. And this was a big deal because cardiovascular morbidity and mortality in both genders is the leading cause of morbidity and mortality in the United States. So for a while, people were prescribing it not just for vasomotor symptoms, but also to decrease cardiovascular events. So as a result of that realization from retrospective analyses, a couple of very large-scale prospective controlled experimental studies were conducted for the primary purpose of assessing whether or not hormone therapy would decrease the incidence of cardiovascular morbidity and mortality. And these were huge studies. I mean, they had multiple arms. It wasn't just about this, but oh gosh, the HERS. I always forget what HERS stands for. I think it's Hormone Estrogen Replacement Study. It was a big study. The Nurses' Health Study, the Women's Health Initiative, these were all, just tons and tons of patients. Collectively, I'm certain millions of patients. And these were prospective studies that had arms designed specifically to evaluate the effect of hormone therapy on the incidence of cardiovascular disease. And surprise, all of these studies evidenced an increase in cardiovascular events in some subjects, And so, immediately, there was sort of a big curtain drop down on the business of prescribing for cardiovascular morbidity and mortality. And then there was this frantic reassessment of the data because everybody was having a fit because, this is big money. What they found, they being all the people who reevaluated this data, what they found was that specifically women who already had a history of cardiovascular problems and who were several years post-menopause, so the mean age is shown for you here, those women did have an increase in cardiovascular events in hormone therapy. So they already had cardiovascular problems, so they already were at higher risk for cardiovascular events, and they were on hormone replacement long after they weren't supposed to have that level of hormone on board. I mean, there is a reason we go through menopause, and the body is always designed to best live in its normal, unaltered physiologic environment. So you have to figure in North America, the average age of menopause is 51. That means that, for those transitional years, it is very reasonable to use hormone therapy to reduce your symptoms, which can really be lifestyle inhibiting in the transition. But by the time you get to be 63, it's probably time to give it up. Just give up the hormones, and deal with the occasional hot flash if they're still happening. Because at that stage of the game, you are subjecting the body to a level of hormone that it was not designed to be exposed to. But it's a really important point. Hormone therapy didn't increase cardiovascular morbidity and mortality in all women. There was an increase in women who already had CVD and also who were older and really probably shouldn't be on hormones. And I mean, I know all my GYN friends will be having a cow to hear me say this because, some of them will put women on hormone for as long as they want it and kind of downplay this risk or don't think it's as significant. I don't know. All I know is the data are there. So I actually have a couple of women in my practice who are well over 63, and they really want to stay on hormone therapy because it does, it makes you feel better. It keeps your skin looking younger. It keeps the reproductive genitalia more like what it used to be like before menopause. And a lot of women want to stay on it. And I make them, I make sure that they understand the risks and make them acknowledge it and sign a thing and scan it into the chart. And then if they want to be on it, they can be on it because it's their bodies. But, whether it's exaggerated or not, the data tell us that these risks do exist in these populations. So current thinking apparently is that there is one subset of menopausal women who may manifest cardiovascular benefit from hormone replacement therapy. Notice the careful use of words like may, because there is no study that supports the use. There's no study that says, yes, younger women who are perimenopausal that don't have heart disease will benefit. All we know for sure is that these younger perimenopausal women do not have a higher incidence of cardiovascular disease. So it's certainly reasonable to give it to them for other reasons, and they may have a decreased cardiovascular morbidity and mortality while you're at it. We also know that this other subset of women that I already mentioned are at a higher risk and may be harmed by it. There is also evidence that women taking certain types of hormone replacement therapy are at increased risk of breast and other estrogen-fed or estrogen-dependent cancers. And I mean, remember, at the end, it all comes back to the fact that the natural evolution of the body is that women over the age of 51, on average, will have a marked decrease in circulating estrogen. And so the body is designed to survive best in a natural environment. There are certain cancers where the risk for those cancers go up as you get older, like breast cancer, and higher estrogen states increase your risk of breast cancer. So, does the risk preclude using it? Apparently not, because lots of women are on hormone therapy and, there's no, what's the word I'm looking for, prohibition to prescribing for them. But especially women who have other risk factors for breast cancer, like a first-degree family history, or especially a first-degree family history with a young mother or sister at diagnosis, for them it probably isn't worth the risk. Also, there is the belief that having estrogen on board makes those same cancers harder to detect, and so they may be more progressive by the time the patient becomes symptomatic. None of this means that hormone replacement therapy is contraindicated in all women. It just means, we got to use a brain. It's not good for everybody, and it is also not indicated for the prevention of coronary artery disease. It's primarily indicated for the reduction of vasomotor flushing, what's the word? Of hot flashes, but I was looking for the professional word. It's indicated for that and indicated for osteoporosis. We do know that there are lots of benefits of hormone therapy. It does all these things: stabilize fibrinogen, increase HDL, all the things that I don't have to read to you. All of those should logically lead to reduced cardiovascular morbidity and mortality. So even though we can't make that direct statement, we know hormone therapy does a lot of things that should logically reduce your risk of heart disease. Other benefits hormone therapy does: promote osteoblastic activity and decrease osteoclastic activity. Remember, osteoblastic activity is the activity that deposits calcium in bone, and osteoclastic activity is the activity that mobilizes calcium from bone. So hormone therapy certainly does increase calcium deposition in the bone and decrease its exit. Hormone therapy does decrease vaginal dryness and increases vaginal elasticity. Like I said, when the husband gets the Viagra or the Cialis or whatever, offer the woman hormone therapy, because in a couple of weeks she's going to be wishing she had it. And hormone therapy does decrease skin wrinkling. Not just vaginal skin wrinkling. I mean, It really is time for the semester to be over. Decreases skin wrinkling in general. A lot of women want to stay on it long past the age of 63 for this reason. I'm quite sure I'll be one of them. It really does make your skin look more youthful. All right, but there are reasons not to take the stuff. Like I said, if you have a high risk, a history or a high risk for breast or other estrogen-dependent cancers, excuse me, if you have liver disease is a contraindication. Clotting abnormalities, because they actually usually mean liver disease, and vaginal bleeding greater than 1 year after the cessation of menses. I mean, menopause is a long process, and for a long time, women may have vasomotor flushing and like irregular or intermittent periods. And this can go on for years, that the periods, like you don't get it for a couple months, you may go 6, 8 months without a period and then have another one. Once it's been absent for an entire year, then generally speaking, you don't expect it to resume. Postmenopausal bleeding, more than a year after the cessation of menses, really needs an endometrial biopsy. You need to figure out why you're bleeding before you put somebody on hormone therapy. Many times it's fine. I mean, sometimes you do just go a year and then you bleed and it's just a big pain in the neck. But the rule of thumb is vaginal bleeding after 1 year. You don't want to put somebody on hormone therapy in that circumstance, and if they have that bleeding, you want to refer them to GYN for endometrial biopsy. Just as a reminder, estrogen is really like the champ here. This is the one that like does all these awesome things and reduces your vasomotor flushing. But if the patient has a uterus, she will need an estrogen-progesterone combination, because the progesterone helps antagonize the estrogen's effects on the uterus and decreases your incidence of uterine cancer. If the patient does not have a uterus, if she's had a hysterectomy, then you can use an estrogen-only form. And I mean, hormone therapy really is the thing with the most global impact on menopausal symptoms. There are non-hormonal agents for people who are really troubled by their symptoms but don't want to take hormones. And a lot of people don't want to take hormones. Some of the other options that you have for vasomotor flushing, Brisdel is fairly new. I think it's just a couple years old now. This is paroxetine, which is Paxil, with a new name and a new dose. I think it's something like 12.5 or 7.5. I don't know. It's not like the same dose as Paxil. You certainly could just, if you want to do this for the patient, but she can't afford Brisdel because I'm sure it's hideously expensive, just put her on paroxetine. I mean, same difference. But if you want to give it to her the fancy name, then it's Brisdel. Venlafaxine is Effexor, and this has been used for a very long time for vasomotor flushing in people who don't want to take hormone therapy. None of them are as effective as good old-fashioned hormones, though. And then for women who have osteoporosis, and this really, and I shouldn't just say women, whether you're in menopause or not, you're just more likely to have osteoporosis after menopause, but men get osteoporosis too. So the treatment of choice, the drug class of choice for osteoporosis, this is a Z-score greater than 2.5 standard deviations below the young adult norm, right? If you have Z-score of minus 2.5 or lower, then you should be on a bisphosphonate. This is the class, I mean, there's a ton of them now. This is the class of drugs that includes things like Fosamax and Actonel and Boniva, and there's just all kinds, like there's a once a year infusion or something. There's a ton of them. This is the drug class of choice for osteoporosis. The selective estrogen receptor modulators like raloxifene, I think the brand name for this is Evista. This is also good for osteoporosis. It doesn't really handle any of the other symptoms of menopause, but for the osteoporotic patient, this is another option if for some reason the patient can't take bisphosphonates. Some can't. Some people, like the oral bisphosphonates, can cause some serious esophageal burning. That's why the patients are supposed to take them with a full glass of water and then remain upright for at least 30 minutes after you take it. This is not a pill you take right before bed, or it's not when you get up in the morning and take it and go back to bed. You have to stay upright. I've actually seen women have serious esophageal burns from those. So anyway, SERMs is another option. And then calcitonin is available as a nasal inhaler. Calcitonin promotes osteoblastic activity. And this one is actually used, I think, more often in men who have osteoporosis. And I don't have any idea why, but that's that. So that is all I have to say about all of that. I believe we are done like forever. This is it. Next week is your final exam. So, as always, you know where to find me if you have questions, and I look forward to finals.